Yeah, so pretty much with a small room, we've got the ability to be a little bit more specific to people. So feel free to ask questions and as we go, because Tracy and I aren't teachers or lecturers, so it's a lot nicer if we can chat amongst ourselves. And then hopefully you guys will get a little bit more detail and be able to apply it to your life a little bit better. So we've got a few slides, but nothing massive to talk about because we wanted it to be that little bit more interactive. So yeah, so pretty much, obviously, I'd like to thank Tracy for joining us. So Tracy's a sports GP at the Australian Sports Doctors in Heidelberg as a co-founder there. So thanks, Tracy, for coming on board.
It's a pleasure. Thanks, Amy, for organising everything. So it's nice to meet people face to face. So or by camera. Yeah.
Sometimes the camera. Exactly. Sometimes the camera at the moment is a bit nicer because we're not all masked up. So that's a bonus. And Tracy, you assist a local shoulder surgeon once a week in theatre. Yeah. Do you want to talk about that a little bit more?
Yeah, so where we work across the road from Ringwood Private Hospital, we're very lucky that we're sort of close by, you know, X-ray and MRI, and we work with a group of specialists, so it makes life very easy. It means that everything's sort of in the same building. I also am fortunate to work with one of the shoulder specialists, Devinder Garawal, so I sort of assist him in the operating theatre. To be honest, he doesn't really need any help, but but it's just nice to have that extra helping hand, and it means that you can kind of just sort of see what happens in the operating theatre, and it means that we can care for the patients, you know, from start to finish. Thankfully, most people don't need to see a surgeon when they've got a shoulder problem, but they're always there as backup or just in case. Yeah,
absolutely. Good stuff. So what I'll do is I'll share my screen and we'll pull up some slides and we'll go from there. Cool. So it's easy. So obviously the shoulder can be a little bit of a troublesome joint to take care of and to identify what's going on and then calm the pain down and then strengthen. And so there's lots of stages, and whether that's stages with physio or stages with docs or surgeons, it's a bit of a continuum at times. So obviously we've introduced ourselves, so we don't need to do that again. But what I thought would be good to do is just go through this little guy here. And so I'll start this and I'll talk my way through it and pause it as we go. So yeah, so the shoulder is a ball and socket joint, but unlike the hip that's quite deep in the bony congruence of it, the shoulder is relatively shallow, and that allows us to have that full amount of movement and reach up and out and across. And so to be able to have that function, we've got a shoulder that is hugely mobile, but that means that we need other structures to ensure that it has the stability. And so you can see that obviously the arm bone here is the humerus, and then it sits in contact with our shoulder blade, and then that is what connects us to the rest of the body. And pretty much the only bony joint that connects the shoulder joint to the body is the where it joins to our collarbone, and then the rest is all either via ligament structures as the shoulder or via the musculature of the shoulder blade. So we'll play it a little bit more and I'll flip around, but you can see as we turn around, there's that little gap in underneath the arch of the shoulder blade here, and you'll see the importance of that as we start adding on muscles. And then you can see back there the kind of near the flatness of the actual ball and socket. It's not, you know, socket is probably a little bit misleading in terms of the boniness of the joint, but when we start adding the ligament and the capsule, that's where we start to create it more of as a socket, but it is that more mobile sort of structure to allow for the movement. And then we've got our rotator cuff muscles, which everyone has kind of heard about, but may not necessarily have a good understanding of. But what the primary role of our rotator cuff muscles, so we've got one here that's highlighted, and then we've got another one up on the shoulder blade, and they will rotate the arm bone on the shoulder blade. And then we've got our supraspinatus, which tends to be the more famous of the rotator cuff. But primarily the role of the rotator cuff muscles is to hold the head of the humerus centered in the cavity of the shoulder blade. And then that's where we've got a really good joint structure to then be able to create the function that we need out of the shoulder joint. And sometimes when either the shoulder blade has changed its orientation, then we might have some extra pressure, say at the front of the shoulder, and we may get some impingement signs. And that's where typically people say, my shoulder hurts at the front of the joint. Converse to that, maybe the ball of the humeral head isn't sitting centered because it's translating forward, or it has a little bit of instability and it's sliding around a little bit. So that's where a few things can go wrong. But in rehab, that's what we're trying to promote, is that centered position in the cavity. And that's what a surgeon essentially does, trying to get that position as well by improving the structures if there's any damage to the structures. And obviously it's not a two-dimensional joint, and we'll spin around in a second and we'll show you the front part of the shoulder. And so here you can see that what's called the subacromial space. So it's where there's the roof, the bony roof of the shoulder blade up here where it joins into the collarbone, and our supraspinatus goes underneath that. And there's a whole, you know, there's a bursa and a whole lot of other structures there as well. It's not quite as simple as this nice little picture. And then at the front, we've got, it will spin around in a second, we've got another part of our rotator cuff muscle at the front here that rotates the arm inwards. And then you can see quite clearly how much the bicep also plays a role with the shoulder. So here we've got our long head of biceps that comes up and will attach right at the back of the shoulder, actually in the joint. So yeah, so you can just see how much musculature goes into the function of the shoulder and the structure of the shoulder. And then obviously I'm focusing in on that subacromial space there. And then you can see just at the back how many muscles are interrelated to the shoulder blade and how our shoulder blade moves. And then this guy gets skin on and doesn't look so scary. So, oops, it's going to play again. Let's exit out of that. Cool. So, in terms of shoulder impingement, I'll throw over to Tracy to chat about that at the moment.
Yeah, no worries. So, when we're talking about impingement, it's exactly what it is. So it's pinching at the front of the shoulder, and the classic area that gets impinged is underneath that acromion. So what Amy was showing us is that roof of that spine, bony spine of the scapula. There's a space under there between the head of the humerus and that bony roof. And there's a few structures, important structures in there that can get easily pinched or damaged. So often this can happen if you trip or fall, or if you have a sudden pulling injury to your arm. But sometimes it can be a bit more subtle than that. So occasionally people might not even remember really injuring themselves, and it might happen, you know, a couple of days after doing some gardening or walking the dog or moving house, and it's not necessarily a sudden injury that you might have. Occasionally these things can also happen if there's been some degenerative change over time. So in the subacromial space, there's, you'll see on this diagram, there's a big blue looking balloon, and they've labeled it as a bursa. In real life, when we put a camera into the shoulder, the bursa doesn't actually look like a big jello pouch like they've drawn in the picture here. It's actually just it's inflammatory tissue that looks a bit like spider webs. So there's no specific start and end to it. It's not kind of exactly like a pouch like you see on these Google pictures, but just gives you an idea of how large a bursa can be. And we have lots of bursas in our body. So they generally form some cushioning between a tendon and a bone structure to stop it rubbing. And if we knock it, you can just get really inflamed and angry. So when we've got impingement, whenever you lift the arm, so you're bringing the arm up, or if you rotate the arm in its socket, for example, trying to reach behind your back or trying to put your bra on, this can cause that the structures in that space to become pinched, and then you get this pinching pain at the front of the shoulder, typically on the front top of the shoulder. The other things that are in this space is one of those rotator cuff muscles that Amy showed us on the previous diagram. So it's called the supraspinatus. So that's the one that comes across the top. And that, if you've got a little tear in that, or an injury or a tendon sort of injury to that tendon, that can also get pinched as well. So this is a very common problem, and the typical symptoms you might notice is pain at that top front of the shoulder whenever you lift your arm or turn your arm inwards, or try and reach behind you. It can throb a bit more at night, and typically the pain can last for weeks or months or be a bit on and off. Occasionally it can be very hard for Amy and myself or clinicians to tell the difference between this impingement and a biceps problem. So you can see that once again on this picture, there's the biceps muscle, and it's got a really long tendon, that long skinny white bit that actually sticks into the top of the joint. So the biceps tendon can also get really inflamed and angry in itself. And sometimes it can be difficult to tell the difference between whether the biceps tendon is causing the majority of the pain or whether the bursa is. So this is where seeing a physio or a doctor who sort of is comfortable examining shoulders and understands them might be useful. And occasionally we might actually need to do some pictures as well, like an ultrasound or X-ray to help us make that diagnosis. So when it comes to impingement, the mainstay of treatment is, if we've got to confirm that the diagnosis is correct. And then the main things that will help is trying to reduce that pain and inflammation. So medication might be useful, like anti-inflammatories or Panadol. Occasionally we might use an injection if the bursa is very angry and very painful, especially if you can't sleep at night or can't lie on that side. Or if it's too painful to do exercises, then we might use something like an injection to give some temporary relief. It doesn't fix the problem, but it can be really useful. But the mainstay of treatment is going to be exercise therapy based as a starter. Did you want to say anything about that, Amy?
Yeah, no, I think that's really good. I think the thing where we come in is, one, trying to work out the diagnostics of it, and often it's not just one clear thing. Often with most of the shoulder conditions that we deal with, I always think of it as a bit of a triangle, and we might have some shoulder impingement, we may have some cuff related pain, and we may have some instability, and sometimes one might cause the other. A lot of the time shoulder impingement isn't normally the primary cause. It's often symptomatic of something else not being quite right in terms of either the structure or the function. So whether, as you said, whether there is a cuff tear, then that changes the dynamics of how the shoulder moves. So then we may have more pressure and therefore more irritation. So the humeral head, again, won't sit nicely centered, and it might start to slide a little bit forward and then really irritate up through the long head of biceps. Or it might start to, as we lift the arm up, it might migrate up and kind of butt up against that bony roof of the acromion. And so that's kind of not just, you know, treating it in isolation, but looking at all of the causative factors. And often, and you'll know, often we'll know whether we can get a relatively good effect is that if we can either change the orientation of the shoulder blade muscle, it's not shoulder blade muscles, it's a bit late at night. If we can change the orientation of the shoulder blade and then we do the painful movement, if that's reduced in pain, that gives us a green light to go, well, I think that we're on the right path. And then if we get the muscles around the shoulder blade working better, then we're going to offload the painful structures in the joint or around the joint. And then we gradually load you up and strengthen you, and then we take away that pain. So I think that often working collaboratively with you know, Tracy and her team is often really helpful, and just having that understanding that if we can make a change early on, then it's a good prognostic indicator. Yeah, so that kind of moves on to cuff tears as well. So as Tracy was saying, with impingement, often it's it can sometimes be because of a fall, but often it's just that repetitive micro trauma or posture related causing that impingement. And the same with cuff tears. Often when we're taking that history, we'll say, was there a moment in time where your shoulder changed? Like, did you fall on an outstretched hand or something like that? And then you go, okay, I think that we're dealing with a traumatic tear. But a lot of the time it can be your 45-year-old office worker, and it's that repetitive micro trauma of using the mouse or sitting in a posture where the shoulder blades aren't that optimal. As an interesting stat, you can have of the shoulder blades. So the shoulder blades sit nicely up against our chest wall with not much tilt forwards. But if you increase the tilt forwards by 7 degrees, you'll decrease that subacromial space by 50%. So if we can orientate you where your shoulder blade is tilted back into a more optimal position, well, then we offload any of those painful structures under that subacromial space. So it helps with that impingement presentation where people are sore when they get into that arc of movement. But it can also be helpful for cuff tears as well. So the cuff tears that we see is, you know, like, or cuff tears or rotator cuff related pain is where we know that the cuff is getting a little bit irritated. Often there's a bit of degeneration around the actual tendon, and that degeneration can then lead into tears, and then those tears can obviously get bigger, and there's different, obviously depending on the size and the severity and the impact of pain and loss of function will direct you down either a pathway to us or a pathway to Tracy and a pathway to a surgeon. But what we know is that we can live with some cuff tears and we can strengthen around it, because as you can see, there are 4 rotator cuff muscles. So if we get them working a little bit better, and then if we can get the scapular muscles working better and even the bicep, then we can offload. And a nice analogy that I've heard lately is that if you think about, because all of those muscles, they form into this tendon, but it's not like one of those tendons that you see when you cut up meat that is this nice round tendon. It's this like flat structure that all merge into one another, and it's more of a blanket that comes around and encases the shoulder joint. And if you think about, if you had a hole in a blanket, you wouldn't necessarily just, you know, get rid of it or think that the blanket's not going to do its job. Like, we can still be quite functional with a small tear, but what we do need to always keep in the back of our head is when's the trigger to get further imaging, or when is the trigger to possibly talk to a surgeon, because we don't want to just be going on with life and the tear extending. And so to prevent that, we really need very good strength around the other muscles, and we need very good strength around the shoulder blade muscles and the big global muscles to support that joint as well. So Tracy, what do you see when you see cuff related pain?
Yeah, I think with cuff tears, there's sort of, I kind of categorize them into so acute tears where you have a really sudden injury. That's usually it's like wrenching incident or trauma. So you've fallen on your shoulder or sporting related, but just sudden onset pain. And it's usually associated with associated weakness as well. So depending on which muscle you tear, so obviously you've got the one at the front, okay, which is quite big. You've got the smaller one on top. And on this diagram, we can see the two muscles at the back. So depending on where that dysfunction is, if it's really gross dysfunction, meaning we've got sudden loss of power and quite severe pain, then if I saw someone like that, I probably would want to know quite in terms of imaging, sort of what the extent of the injury might be. Because we know if you've got a full tear and you're a very young, active person, for example, that's your, tennis serving arm, or that's, or you're a young mother and you've got, and you're caring for a baby who we know is going to get heavier and heavier. Then, or your job's like, if you're in hospitality or you're in a labour job, so sometimes I see tradies who'll come in with these kinds of injuries, then it might be useful to have imaging like an ultrasound done a bit earlier, so we can actually see. And if there's a very large tear in that muscle or tendon, we know unfortunately that although the body is very clever and has potential to heal, a very large tear is not going to be able to heal. And like Amy said, we have to rely on the rest of the muscles around that shoulder to function. So we've got to make sure that the rest of the shoulder can cope. So a large tear, occasionally it'd be something that we'd think about referring to a specialist early. But generally speaking, most people don't come in with an injury of that sort. It'll be a lot slower onset or a lot more functional. And in that case, which is the vast majority of the cases, it's going to be really suitable to try and conservatively manage this for at least 3 or even 6 months. So seeing if we can get the rest of those shoulder muscles to compensate and get you doing the things you need to do. So when I meet people, I'm always interested to know, what do you like to do, what do you need to do, and what do you want to do. So, and what's this, what's your arm stopping you from doing? And often if we can get the pain down enough for you to do good quality rehab and actually give that enough time, being a matter of many weeks, then we can make a decision whether, that's good enough for what you need to do. So,
yeah, absolutely. It's that moment in time where something changed and making sure that we're acting quickly in those moments of time, for sure. So then in terms of frozen shoulder, Tracy, you want to talk about frozen shoulder?
Yeah. And whilst we're talking, I'm very happy because we've got a small room tonight. I'm very happy for you guys to unmute, and you don't have to be too shy. So if you want to interrupt or ask any questions, you're very welcome. Does anybody want to ask any questions before I have a quick chat about frozen shoulder?
I had a quick one just on the comment you made before, Amy, about the rotation of the scapula, like the forward rotation of the scapula, and that's 7 degrees. How is that sort of determined where kind of the normal position is and the normal angle? And then apart from on, huge sort of, I suppose, data samples where you measure a load of people and X number have pain and theirs seems to be in a different position. Like on a case-by-case basis, if someone came in, how hard is it to sort of go, oh yeah, you've got a slightly, you know, anteriorly rotated scapula, so X, Y, Z.
Yeah, yeah, absolutely. Like, I'm sure, you know, I gave a very specific 7 degrees, and I've got no idea how that research was performed, because everyone fits differently and every rib cage is different, obviously. But in terms of what I look for is, so if I was to go side on, and you probably can't see too much because of my dark top, but you can see some people just will sit with that tilted forward position. And so you see that in different populations. So you see it very much so in the desk worker, and especially the data entry accountant style, where they're doing mouse and, you know, keyboard, like data entry. And so then it's that repetitive micro trauma, because like it's just, yeah. So in terms of what I look for, you can often see, if we go back to the picture of the shoulder blade.
Is there like a winging of the scapula where it's starting to stick out at the bottom a bit more?
Exactly. Like often we can, like I can pick up the inferior, like the bottom angle of the shoulder. And so if I can pick that up off the chest wall, I know that it's tilted forward.
Yeah.
The other really big obvious thing that I look for, and this skeleton guy isn't actually doing me any favors, but I look for the angle of the collarbone too, because a lot of the time we'll have quite depressed scapula, and so they'll be sitting quite down, and so then that again adds that compression. And the rotator cuff is pretty sensitive to compression or compressive loads over time, and so if we're constantly down here and then we might have that little bit of a tilt, then that can really be quite irritable. And so then in terms of whether I think that it's important or not, people come in with pain, and so I'll find the painful position, and then I'll correct the shoulder blade position into more of a tilted back position and see if that corrects the pain, or it might be a combination. I might have to tilt it back and elevate it up. Does that make it better or worse? And then again, as I said about the shoulder, the ball, maybe I need to suck that, like bring that ball back, especially if we're talking at the, you know, anterior or front, like shoulder sort of anterior pain. So yeah, so that's kind of how I determine whether it's important, because like other research will say that actually, you know, posture doesn't really mean anything. And that's the difficulty of our jobs, is that randomized double-blinded control trials only tell us so much information, but it's applying that information to the person that you've got in front of you and their variations to anatomy. And their tendons might be happy in that load because they've always been like that, and they're conditioned to that load. But if there's been that moment in time and it's a little bit irritated, it can come back, and it might just be temporary. Like, it doesn't mean that you're going to have your shoulder up and back like this forever. It might just be until those structures, you know, calm down. It's like, you know, Tracy might give a cortisone injection or a local anesthetic into the structure that's sore, but before that, I want to kind of tape it up and stop the irritation from a mechanical point of view to give it that calm down effect. Does that answer your question?
Yeah. Yep.
Good question. Yeah. Do you have anything to add on that, Tracy?
No, but you're right. I think at the end of the day, it's, you know, the assessment's going to be dynamic. So you're going to be teaching or showing people where their scapula or where their shoulder blade needs to be sitting in relation to that rib cage, that it's sort of, we need it to glide rather than be tilting. But we also want the muscles around that shoulder to be balanced as well, in terms of you know, the strength, so that it's not protracted, it's not sort of, you know, hunched forward, and you don't have to manually sit there. And so with my shoulders, I have a little bit of, because I do a bit of aerial work, so I'm quite pec dominant, so I've had to train those muscles at the back of my shoulder and my back as well to even it out so that I don't have hunchy forward shoulders. So for me, it's not just about, I mean, also doesn't look good, but it means that I don't have to walk around like trying to forcibly hold my shoulders back all the time. So it's just more about being aware of where your shoulder needs to be in time and space through a range of different motions. So that's why working with the physio is really important. So someone like Amy really understands that the functions. So like, I need to do this, I need to do this, and build a functional strength. So a strength, in other words, doing the things you need to be doing on a daily basis. So that's why I think physical therapy is really important. So in my job, it's very easy for me to prescribe exercises, but I think people do better when they've actually got that face-to-face or hands-on interaction. So you can kind of work with your therapist to show you whether you're doing the exercise correctly or not, and help you to understand where you want your arm to be at various points in time during various activities. So I think that's really important. And whether we're not sort of sitting there measuring the 5, 6, 7 degrees in real life, we're sort of having a look at you moving and doing things, and we can tell you whether there's winging there, or because you actually can't see it yourself unless you've got a mirror. That's really good. I might talk a little bit about frozen shoulder. It's a really common condition. So most of us will probably know someone who's had a frozen shoulder before if we haven't had one ourselves. So we're still not really sure medically why people get frozen shoulders, but we know it's associated with a few things. So it tends to be more common in people sort of in their 50s, 40s, 50s, and it increases with age. Seems to be slightly more common in women as well. We're not really sure why. And there's an association with certain diseases, so certain autoimmune conditions. So if you've got diabetes, thyroid illness, inflammatory bowel disease, you've got a slightly increased risk of this happening. So we can see in the diagram here that all the muscles have sort of been taken off this diagram, and you can see that there's some pink tissue there which is being labelled as affected joint capsule. But basically the ball is held in its socket by some thick fibrous tissue, which is called the capsule. So it actually encapsulates or covers the whole head or the ball basically, and it holds that ball into its socket. And in some people, there's inflammation that occurs and it affects the whole capsule. So it doesn't affect one part of the capsule, but once it's affected, it affects the whole thing. And it gets really angry and really inflamed. And then over a period of months, it gets really tight and becomes scar tissue. So you can see the box diagram there where it's pointing to adhesion. So you start to get all these little spider web kind of looking scar tissue forming, and it forms around the whole joint. So this is a very painful condition, and often we'll see people in the early phase when it happens, and it can be actually excruciating. And that excruciating phase can last for months, and often that's when people will come to their GP or occasionally can go to the emergency department, and definitely they're booking in to see their physio, and it can be quite distressing. So the key with frozen shoulder is that it's global pain. So it basically hurts in any direction you try and move that shoulder. And in some people it'll be so restricted that they can barely only lift their arm, not even halfway up, or they can't even reach round the side towards their hip pocket. And it's quite debilitating. But as you can see in this diagram, in the chart, so it says there's a painful phase, and that painful phase on the chart's 4 months, but in real life it can be longer or shorter than that. And the pain starts to reduce over a period of time, and as the pain goes down, you start to get more of that scar tissue forming, and it just starts to become stiff. So we call this the frozen stage, or basically when the pain's starting to come down, and then we start to get stiffness. So what I find in my patients, I don't know if you can see me on the camera, is that we start to lose this range of movement. So the external rotation, which is tucking your elbow in and you turn your arm outwards. And that's one of the main movements that we might lose. We also might lose abduction, which is being able to bring your chicken arm out that way, and flexion, which is going forward. And reaching behind is generally the worst. So we start to notice this stiffness or this loss of movement in all directions. Whereas if you've got impingement, like we talked about, you tend to only sort of really have problems up here or right behind you. Or if you've got a cuff tear, you tend to only really have that pain or weakness in one plane. So depending on which cuff muscle you've torn, right? So if you've torn the one at the front, then you'll have trouble with certain movements or pushing downwards. So the key with frozen shoulder is it's often quite painful and it's global, and then it progressively gets stiffer and less painful. So in the green part of the graph, you'll see that eventually the red line's gone right down, and pain's not really so much an issue after 8, 10, 12 months, which is a really long time, but that's what happens. But the stiffness doesn't improve. So unlike other conditions, as the pain goes down, you still can't move your shoulder. And we find that physio pushing on the shoulder, stretching the shoulder, keeping those muscles moving might help, but generally speaking, it's going to have to run its course. And most people will, the good news is most people will get there on average at about the 2-year mark. But a lot of people don't have that much patience or time, depending on how bad their movement is. So at the 2-year mark, we find that most people have got a reasonable range of movement, but usually it's not 100% back to where you were before. So the important thing with this condition is that we can't really see it we can't see it on X-ray, because X-ray you just see bones, you can't see that scar tissue. And you can't see it really very well on ultrasound either. So because it can be quite subtle. So it's something that you would diagnose, the diagnosis will be given to you by your physio or your doctor. And it's usually a suspicion, because over time it becomes a lot more obvious that's what it is. You can see it on MRI, but MRI is not required to make this diagnosis. So I find the most important thing with this is getting the diagnosis so that people know what to expect, and getting that pain under control so we can try and maintain the range of movement. And the treatment for this is, if it's not improving over time, is to do a hydrodilatation, which is basically injecting a fluid into that joint and trying to expand the joint like a balloon. And what you're doing is breaking up that little bits of scar tissue so that your arm can move in its socket again. But doing that procedure during the painful phase is very, very painful. So we wouldn't recommend doing that procedure during the painful phase. We'd actually wait until that pain level's a little bit down, or you've had an injection for pain, or you've got some pain relief tablets. Then we might consider doing that hydrodilatation. And it's often quite successful, but once again, not 100%. And straight after having a hydro, you pretty much want to see your physio and get your shoulder moving like 1 or 2 days afterwards. So yeah, it's a procedure where you don't really want to rest your shoulder afterwards. You want to get it moving as soon as possible so that it doesn't scar up again. So the other thing with frozen shoulder is it's not like this nice graph in real life where everything continues to move forwards. In real life, it's a little bit forwards, a little bit backwards, a little bit forwards. So frozen shoulder is one of those things that can ebb and flow a little bit. It's not necessarily a forward motion all the time. And I'm sure you see a lot of frozen shoulders, Amy. They can be very stubborn, but I always tell people you're going to get there one way or the other. And yes, there is an operation you can do to break up the scar tissue if you have to, but that's more as, you know, if we're running out of options.
Yeah, definitely. Yeah, it's a pretty common condition that we treat, and we're not very light when we do treat it, because obviously we can't do much in the painful stage, and we're just trying to calm things down and maintain as much range as possible, and just educating that it's going to run its course. And then we start to have a bit more of an active role when the pain's reduced, and we're just trying to help encourage that movement. Or if they've had a hydro, then we're getting in and making the most of that hydro and getting as much movement. But yeah, there's often a little bit further discomfort on the physio table than usual when we're dealing with frozen shoulder. But as you say, it does get there, and it's a nice day when it does. And it is incremental, and there's more function that happens. But it's about picking when you want the hydro, and going from there as well. And then also picking if you don't have those 2 years to wait, and seeing a surgeon and getting an opinion there. Because if you've got and there's different degrees there. Like there's some people that you rotate them out and they've got nothing, or they've got not even neutral, and they're here and they just can't function with that sort of limitation. So whereas some people will have this frozen shoulder, and they'll have some level of functional movement, but they won't be able to hang the washing out and those sort of functional activities. So there's a spectrum that happens too. Then the last little topic that we were going to chat about was shoulder instability. And like we were talking earlier, it tends to be, sometimes it's not in isolation. Like obviously with Chris Judd here, I don't know how many times he dislocated his shoulders. And you can obviously see that by the amount of taping that is on both shoulders. So there's quite commonly the traumatic dislocated or unstable shoulder, and that's obviously when the shoulder comes out of place and stays out of place. And then we've got the subluxing shoulder, where it will slide and then come back into place. And that is, if you think about the capsule of the frozen shoulder, where the shoulder capsule gets quite tight in these stable patients, they've got more room to, they've got more laxity in this tissue. And so there's more either sliding forwards, sliding backwards, sliding down. You can have one, you can have two, you can have all three in a trifecta. And so that's where what we want to look at is, was there that moment in time where your shoulder completely dislocated? Or was there a moment in time where you felt your shoulder slide and then slide back in? People will describe that quite clearly, because it's a very uncomfortable thing to happen, and often it will be then associated with, if it's going to slide forwards, it's going to irritate those structures at the front, or if it slides out the back, you're going to get some pain at the back as well. So it's about identifying that moment in time. Obviously with a full dislocation, we're then worried whether you've got some cuff tearing or some tearing around the labrum and capsule. And sometimes you can have a fracture as well. So then we're obviously using our multidisciplinary approach and getting Tracy involved and having a look at some images to see if what the level of damage has happened in a full dislocation. But then sometimes there's the subtle instability clients that come in, and they tend to be, again, not that moment in time, just possibly small moments built up over time, and they might actually present more in that impingement pattern. So they've got lots of movement, but it hurts in this position, or lots of movement, and when they come across here, they get pain at the back. And sometimes it's not that direct, I've got pain here. They kind of come in and go, I don't know, it kind of hurts here, sometimes it hurts here. And they might have apprehension. I don't like getting into this position. or, you know, if I carry heavy bags, sometimes I feel like it slips. So there's that sort of, you know, presentation. And then when we look at the movement, you might see the humeral head move in a pattern that you're not like thrilled about, because as the arm comes up, you might see the humeral head slide backwards, and so forth. So there's lots of tests that we can do to rule it in or rule it out. And then it's a matter of, well, if it's traumatic, we want to get bigger pictures on that. But if it's this like bubbling away, well, if the capsule's not doing a great job, we want to get the muscles to do a much bigger, better job. So often with these instability clients that don't have those moments in time, it might be like, you know, a typical one is a teenage, female athlete, and she's just not very developed muscularly, and so the joint's sliding a little bit too much. So then it's our job to bulk her up and get the muscles to do the job that the capsule probably isn't doing great at the moment. And then it might be like your overhead athlete that's done the repetitive micro trauma with the tennis serve, and it's created, there might be a lesion in there from the repetitive use. And then it's like, you know, when you have a cylinder of tennis balls and you haven't taken the lid off it, and the balls are nicely secured and there's not much movement. But if you pop the lid of the tennis balls, then the balls move around more because that negative pressure has been broken. So sometimes if there's a tear, or if there's a tear in the capsule, sometimes that negative pressure is broken, and so, or lost rather. So then there's that increased translation of the joint, and then that's where we'll see that instability. And then we'll see it in the irritation of the front structures, and it'll present quite impingement-like, or it could, you know, that constant movement or irritation could lead into a cuff tear. So yeah, so that's kind of what we see, but primarily we want to get people nice and strong in ranges, and first we have to obviously get them strong down in safe ranges, and then get them progressively stronger, so that then they can, you know, be confident in positions that is, you know, notoriously unstable in the shoulder, and then obviously make it specific for sport. If they're a tennis player, we want to really build them up at the front, so that then that, you know, the anterior deltoid is doing a good job and holding that joint in place. But if you're an AFL footballer and you're going up for a mark and you've got a 100-kilo bloke going to land on you, that's why it's like, you can see that no shoulder can really withstand that amount of force. And that amount of bulking up from the physio, which is why Chris obviously has taped his shoulder to the inch of his shoulder's life. So what do you want to add to that, Tracy?
I think you've pretty much covered. I think that with shoulder instability, it comes down, for me, when I talk to patients, it's more about what symptoms that they're experiencing. So whether they're getting recurrent episodes of that shoulder half popping out, which is subluxation, or if they've had recurrence of it actually dislocating. So if the shoulder is very unstable, like if it's previously completely come out of its socket before, usually because of an injury like playing footy, occasionally it can just start to pop out with doing minimal things, so not even having a fall. But I've had patients who, you know, they're just reaching around to the back seat of their car because to grab something out the back of the car, and just that sudden putting their arm in that sudden position of vulnerability, it's kind of popped it out. So if that shoulder is so unstable that it's popping in and out on a day-to-day basis, doing simple things, then that's something that I think will be very difficult to stabilize with training the muscles around it. So when your shoulder pops out of its socket, it will tear, almost always it will tear or damage the lining of the socket, which Amy mentioned before. It's called the labrum. And occasionally you might even shear off a bit of the bone at the front or a bit of the cup itself, which just makes it easier for that to happen again. So in these patients, unfortunately, the only thing that's really going to stabilize their shoulder is a surgical procedure where you actually either put a little bit of bone at the front or replace the bit of to make that cup, more stable, or we actually put some stitches in with the labrum. So we actually, increase the surface area of the cup by repairing the cartilage that was torn. So these things work, but they're usually, we would do this for someone who's got obvious instability. But otherwise, I think the main thing is like Amy said, is trying to get the rest of the muscles around the shoulder to support it. The only other thing to mention is I really like that tennis ball in the canisters analogy. So you can kind of imagine if things aren't, if you don't have that negative pressure, that vacuum pressure kind of keeping that ball in the socket, and it kind of jiggles around a little bit more, over time what happens is the cartilage in that joint starts to wear out as well. So people with instability are predisposed to getting arthritis at a younger age. So all these young sporting heroes that they get arthritis in their knees and their shoulders, etc., at a much younger age than people who weren't as active when they were younger. And it's because their shoulders and joints, the knees and shoulders have been knocked around. So they haven't all had dislocations, but a lot of them have had quite a heavy number of knocks and blows. But something and the more you traumatize the joint, the more likely you're going to get wear and tear, which is arthritis. But people with instability also have arthritis. It's important to point out that stabilizing the shoulder with surgery is not being shown to reduce your chance of developing arthritis. So that's not the reason we would stabilize someone's shoulder. We'd only do the surgery if your shoulder continues to be unstable or keep giving you symptoms of pain.
So in regards to physio management, we've kind of talked through it a lot, but I think the biggest thing to focus on is to give a good understanding that it's not a linear straight line up in terms of rehab, and shoulders are quite complex because they've got such a degree of range and we use them so much in just our daily living. And so what we need to do is get you strong quite low down first. Well, first we have to calm pain down, and then we can, once we've got that window of opportunity, then we find the right amount of load in the right position. And so we often will start that loading in a low, safe position that won't be quite irritable, and then we'll get you a little bit stronger in like these lower ranges. And people will go, yeah, my pain's still the same. And they get quite frustrated because it's been a few weeks. And the problem is that their pain's the same because we've only strengthened, belly button and below ranges, where life normally happens at least at shoulder level and, down 45 degrees. And then so much of life also happens reaching for the top shelf or throwing the doona cover over the washing line. So, it's giving that expectation that you're still going to have pain until we get you strong up in these ranges, and then even more so once you're strong in these ranges. And so that takes time. Obviously, you don't need to be seeing us that regularly as we're progressing up, but it is a real commitment to the process. And so I think it's really important to have that framework, because otherwise you get quite disillusioned quite quickly and then think physio is not working. But really it's just that framing that expectation. And then the other thing is that, the shoulder is designed to carry things, it's designed to push, it's designed to pull, and it's designed to, to reach and lift. So, when we're designing our rehab, we want the shoulder to do all of those things. And I think that physio fails a lot in just giving little red band exercises and some dumbbell, like 1 kilo, 2 kilo, because that's not increasing your joints capacity for the demand of life. So we have to get you quite strong in quite large ranges under load. So, you know, we want you lifting, and we need to get you lifting 10 kilos quite easily, because if you even just think about your shopping bags, like, you know, a couple of bags of, you know, milk and some yogurt tubs and those sort of things, that can be quite demanding, let alone maybe just lifting up a grandchild and putting grandchild into a car seat. Like, you know, all of a sudden you've got a 15 kilo weight that you're putting into a car seat. So, you know, I think that we need to do a good job at actually giving you the confidence to lift heavy weights and condition you into it. And then obviously that means us having the window where you're not irritable and we can move through that. So if we're not hitting those targets, then that's where we're working a little bit more collaboratively with Tracy to help with some pain management. But then also going, well, we might get you strong to this degree of range, but something's just not working. And we might go on that 3-month track of giving physio a trial before we escalate it to a medical intervention or surgery. But if we're just hitting that ceiling, well, then there's obviously something structural that maybe we need to get a picture of and have a look. So that's kind of the bare bones or the goals of physio when we're dealing with shoulders. And then it's not just looking at the ball and the socket. Obviously, it's definitely having a big impact at looking at the shoulder blade. And then the thoracic spine plays a big role, because as you say, like like we were talking about it earlier, if you're completely rounded through your thoracic and you're not rotating much, well, then your shoulder blade is going to change your function too. So we want to have a look at that. And then sometimes it affects, like, you know, we've got neck related as well, and it can get a little bit complicated, but it's not just looking at one joint in isolation. We're often looking at multiple things, but through range, through, you know, task specific and life specific, and then looking at what you're doing in terms of your life and modifications. And sometimes it's about us, you know, really questioning what you're doing and maybe giving some modifications, or going, okay, well, you know, like the typical one is, you know, Tracy was saying that she's quite dominant through the front of the shoulder because of what she does in terms of sport. Often we find that the case in general life anyway, because we drive, we sit at computers, we cook, we look after children, and it's all a lot like forward tasks. And a lot of the time we need to focus on the scapular muscles at the back and the back muscles as well. And then you might have your 21-year-old boy that comes in and all he's been doing at the gym is biceps and pec work because he wants to look good for summer at the beach, and he's completely neglected all of the back muscles. And you say, what do you do for back day? And they say, I do lat pull downs. But there's just like looking at the whole picture about what's happening outside of work, what do you do for work, and all of those sort of things is really important to look at. So that's the physio role, I think. And then obviously to be constantly checking and reassure and making sure that we're on the right trajectory, or whether we've hit a ceiling and we need further intervention or investigation. So cool. And like we've talked a lot as we've gone about medical management, but is there anything further that you want to talk about, Tracy, about medical management and surgery?
We don't want to repeat stuff we've already said previously, but I think with medical management, it's pretty much, I think when I see a lot of people, I think sometimes the assumption that a lot of people make is that, you know, taking painkillers or relying on painkillers is bad, or it's not going to fix the problem. So the way I see pain relief is pain's there for a reason. It's usually protective. So initially when you've got pain, your body's trying to tell you something's going on and to back off. But once we know what's wrong and we know how to fix it with exercise therapy and with time, then we've got to kind of make sure that pain is manageable. So it's not getting in the way of you actually doing your rehab. But on the other hand, we don't want to ignore the pain. But I kind of explain to people sometimes, especially with tendon injuries in particular, pain is not necessarily always the best gauge. So in other words, when it comes to arthritis and when it comes to tendons, the severity of the pain doesn't necessarily tell you how bad the condition is. So sometimes we do have to kind of dampen that pain down in order to be able to achieve our rehab goals. And we do respect the pain, so we want to make sure it's you're not just pushing through it for the sake of that. But on the other hand, we don't want to be scared of the pain either. So sometimes I see people who are like, oh, there's a bit of discomfort there. I must be doing the wrong thing. I think I've overdone it, and they just kind of lose their confidence. So we kind of have to develop a bit of a language about what's appropriate when we're talking about pain. So I do a lot of that. We talk a lot about pain psychology, pain management strategies. And the reality is pain's a sort of a personal experience. So if there's a lot of other things going on, stress, sleep's not good, or nutrition's not great, or for example, we're struggling with a pandemic. So all of these things can really affect your well-being and your experience of pain as well. So part of medical management is really making sure that that we're confident that we understand pain and what to do about it. And we've got a few things up our sleeve as well, whether that be, like I said, Panadol or some prescription anti-inflammatories or something. But we don't want to feel like we're completely powerless. The other thing is occasionally there might be the role for supplements. There's not a lot of evidence for supplement use outside of arthritis, but I'm talking about things like fish oil, glucosamine, turmeric. So the jury's out that most of those things have very low evidence for them, meaning they're probably not harmful, but it's not guaranteed that it's necessarily going to help. But I do talk to my patients about some of those things as well. And I think the word surgery can also be, it can sound like a bit of a bad word. So depending on what the problem is, we often just have to have a chat about what surgical options there actually are. And you'd be quite surprised that some of the surgeries that we do or have available, actually the recovery can be very quick, and they don't have to be last resort. So the example is for frozen shoulder. Even though most people wouldn't need surgery for it, if you have felt like you've tried, gotten through that painful phase, you've tried a hydrodilatation, you've done lots of physio, and you still don't really have enough of a range of movement for you to actually do what you need to do in life, you don't really want to hang around and see what happens after 2 years, then you can have, it's called a capsule release. You can have a keyhole arthroscopic surgery. And it's a day procedure. You go in, you go home before lunchtime. The actual op really doesn't take very long. So from our point of view, it probably takes 15, 20 minutes just to break up all that scar tissue. And we do it under camera so we can see exactly where we're putting the camera, and we zap or break down that scar tissue with a little, it's like a burning wand that works underwater. So it's quite an interesting tool. And we actually get the shoulder to move. So often people come in and that's as much as their shoulder will move. But by the end of the procedure, we're actually able to move that shoulder through a normal range. Then you wake up with your arm in a sling and you basically ditch the sling after 2 days. And there's been no other surgery done on the inside. So you've got a couple of tiny cuts in the skin and that's it. So within a few days, you're up and about and you're moving, and there's effectively not really any recovery time required. So that's an example of a day procedure and operation which, you wouldn't need to take a lot of time off from work for, and the effects sort of almost immediate. You still got to rest your arm a few days after because you've got a couple of cuts in the skin, but the actual adhesions have been broken down. So Whereas, you know, if you have a large tear in one of the rotator cuff tendons, the surgery for that's a little bit more involved, and the rehab for that's a little bit more involved. So we sew the tendon back down to where it's meant to be, but there's a good six to 10 weeks of rehab afterwards to build that tendon strength, let it heal, get you back to where you need to be. So sometimes the rehab is just as important or more important than the surgery itself. So having someone like a good physio who you've known beforehand, so if you do your exercises before the surgery, it actually makes your recovery better afterwards. So we call it prehab, basically. But the more prehab you've done, the better you're going to do afterwards. It's kind of like pregnancy. So the fitter you are before, you know, you go into labour, hopefully the better experience you'll have when it comes to pushing and having to, you know, look after baby afterwards.
Good analogy.
Anything else? Does anyone want to ask about anything specifically with regards to management things, or like I said, it's pretty informal tonight, so doesn't even have to be whatever we've talked about, to be honest.
Yeah, we can just stop sharing because that's the end of our slides anyway. But yeah, now's your time to ask away if anyone's got any questions. Good. Yeah, if anyone has any specific questions to obviously their particular shoulder, obviously you have Tracy and my details that we can talk to in more detail, because obviously every shoulder is a little bit different and every person is different. But other than that, like, we really appreciate your time, and hopefully you got a little bit of value out of tonight. Because yeah, as we say, it's quite a complex joint, and there's lots of things that can be done to improve your function and in pain as well. So yeah, but other than that, we really appreciate you talking shoulders with us over the last little while.
Well, thank you.
Tuesday night.
It was really helpful for me to see, you know, your skeleton bloke, and then to pad him out and to see how everything works and ties in. I've never seen that before, and it helps me visualize what goes on inside me. So that was really, really helpful. And I'm looking forward to you creating a program, Amy, whereby I'll look like that lady on the lifting the weights.
Yeah.
Okay.
Absolutely.
So we talked about commitment and discipline. Yeah. Okay.
Yeah.
So there's a challenge for you.
Anything's possible.
Yeah. Good. Okay.
The next presentation due next year, Amy, then you can have it'll be a slide with Kathy, sort of.
Yeah, that's right. Before and after.
Before and after. Absolutely.
That's
good.
Fantastic.
Good stuff.
Okay. There's a challenge,
Thank
Tracy.
Excellent.
Good stuff. Do
Thank
you have any questions, Simon?
Sorry?
Do you have any questions or anything that we can help you with?
Not really. I think I asked 1,000,001 questions through that I've been seeing you.
Yeah.
I think my biggest frustration with it is, even though I did a lot of the physio, it sort of was still very niggly. Which I know I was going to end up seeing Tracy, but then COVID and it fell to pieces.
Yeah.
And my TheraBand perished out on the back deck. So that's why I've ordered another one.
Yeah.
They're not. I found out they're not UV resistant.
No. They'll break down a bit there, won't they? Yeah. But
yeah. So I guess as things look to ease, I just want to. I've been doing bits of exercise, but not a huge amount, and it's not degraded in any way, or it's sort of remained consistent. So I thought it's probably time to get stuck back in and see if I can get another step of improvement with it. But yeah, there's certain things like at the gym and doing exercise that are still just niggling. So it's
yeah,
the problem and quite annoying. But day to day, it's generally fine. Like getting up and down and doing stuff with the kids, it's okay. I've lost that. I suppose where I'd be sat with my arm around, say, my daughter on the sofa, and then I'd move and it would hurt. It's like that sort of very fine pain's gone. It's just more of the sort of the heavier exercise that is a problem.
Yeah.
Okay. Well, that's an improvement since last time I saw you.
And if I do then make sure it's in the right position, it is a lot better, but it's just making it be in that right position the whole time that tends to be the problem.
Yeah. And that's kind of like what we were saying, like we get you to a point and then we need to reevaluate if we can take you to that next step or whether we need that further intervention and pictures taken and to see what's going on in the joints itself. It's very, when there's quite like those loaded positions and you're getting that deep pain, sometimes we can live with it. But if it's not getting better and it's really impacting your life, that's where we need to take that extra step and get some further investigations done and go from there.
Sounds like you worked really hard with it, Simon. So everything's work in progress, and there's always a little bit of, like I said, backward, forward kind of thing. But as long as you're heading in the right direction and you keep shifting your goals, so don't be afraid to tell Amy exactly what you want to do. So, and then she'll tell you if it sounds realistic or not.
But you're one of my most diligent. So it's not from lack of trying, that's for sure.
No, and the weight was increasing and it was fine, but it was, you did notice like certain movements would be fine, like deadlifts and things like that are completely fine. But then to do a fly, if I'm lying on my back, like a 6 kilo weight in my hand would just break it. Whereas, you'd be able to fly like 20 odd kilos and stuff like that. So and the left arm's fine. It's the right arm that just.
And from my point of view, there's always something that we can do, but it's just more whether it's appropriate and necessary, right? So
whether the risk.
You don't want to pull out all the big guns every time, but there's always something you can do. So I never believe that people are complaining. I always think if it's bothering you, then speak up and don't be shy about it. And obviously we make sure we're all on the same page. So
yeah, definitely. That's good.
Excellent. It's been very nice meeting you guys. So
thank you very much. All right, it's good stuff. Well, thank you again. And
good luck with all your shows
around.
Lucky we've got two.
Exactly.
All right. Thanks so much, Amy. It was really fun. Have a good week, everyone. Bye.
Thank you.
Bye.
Bye-bye.